Well, welcome back, everyone. Good morning. Just a quick introduction to day 3 of IMUC-III, and welcome to colleagues that are joining us for the first time for this session on diagnostics. And some of us will be a little weary. Those that were on the bus yesterday, we had a very enjoyable trip down to the Mornington Peninsula that was informative, convivial. And yeah, I don't know, for me personally, it was an exceptional conference gathering or dinner. So anyway, thank you for all of those that made it such a wonderful experience. But the show's not over. We have a very informative, interesting, engaging day today. We're switching gears. We're going to be dealing with diagnostics and treatment. And we have some really leaders in the field in diagnostics to kick us off. I'm going to hand over to our chairs, Katherine, Bond and Yo, to lead the next session. Thank you.
So good morning, everyone, and good to see you all again. I had so much fun yesterday. I wasn't sure I could wake up, but I did, and that's the beauty of these things, that usually you have so much fun on the field, and when you think that you would not make it in time, you come 15 minutes ahead of time and everyone is already here ahead of you. I don't know how you guys manage to do it. But this morning's session on diagnostics, our first speaker is somebody who we know quite well. So Sarah Yango is director at the Institute Pasteur in Cameroon, and she leads the Skin NTD lab nets. She's for over 20 years been actively involved in the diagnosis of mycobacterial diseases, as well as research on molecular epidemiology and control of these diseases. She's been involved in training nationally and internationally, and she's a giant in the sub-Saharan African region. She researches on evaluation and implementation of new diagnostic tools, mycobacterial genetic diversity, and disease risk factors. Like I said, Sarah is the coordinator for the Buruli ulcer lab net, which has now transitioned to the Skin NTD lab net molecular diagnostic laboratory network in the whole Africa region. Sarah, we are happy to hear you speak to us on Buruli ulcer diagnostics, the role of the BU lab net. Let's give it up.
So thank you for the introduction. So we really enjoyed the field trip yesterday. We enjoyed food and drinks, but although it's not easy for us, it's really hard to believe that we were in a Buruli conference. Thank you very much for inviting me. So I would like to share with you today my experience, my field experience on Buruli ulcer diagnosis, which inspire now skin neglected tropical diseases, perhaps in the future, or NTDs. So, okay, I was changing the title many times, but it's just, I think it's just my journey on this. So I would like to start by emphasizing that molecular diagnosis is a key component of management of diseases. That is a key component of management of diseases. In addition of that, the use of molecular diagnosis really reduces the time of results. It's really increased the specificity as well as the sensitivity, and so we can also directly detect many pathogens. So with that in mind, I would like now to share my journey to improve this Buruli ulcer diagnosis, from the implementation of the diagnosis in our country to training African people to implement also diagnosis in their country, organizing laboratory network for Buruli ulcer and on skin NTD. So the first step is from 2000 to 2003. when Buruli ulcer was declared a public health problem in my country. So I was a young scientist back in the country in the mycobacteriology laboratory. So my expertise was molecular epidemiology of tuberculosis. I came there to implement research work on TB, but there was another challenge. More and more cases were reported for Buruli ulcer, and really we challenged. There was no capacity to do diagnosis. So in 2001, the Ministry of Health at that time organized a survey to describe the situation in this endemic area, but also to collect samples. So we get samples, and we're not able to do diagnosis. So samples were sent at that time to Professor Gerd Pluschke lab, and also to Professor Portal's lab. So to do the confirmation of cases, and these were published later on. So at that time, we decided, based on the opportunity was that we have this molecular capacity with the support of the National Reference Laboratory in Pasteur, Paris. So we decided to also introduce Buruli ulcer diagnosis in our lab. So we succeed to introduce Buruli ulcer, and we start now doing diagnosis, molecular diagnosis in our own lab. And so based on that, I participated in the first meeting, March meeting, you know, the March meeting in Geneva. At that time, it was in 2003, I participated to the first March meeting. And when I reached the place, we saw the presentation, and I just realized that we were almost the only lab able to do diagnosis in the armed country. The other samples were sending around in Europe for diagnosis. So the first idea was how to train other people also so that they can do their own diagnosis in the country. We started then looking for funds to organize training, and we get funds, first fund on 2005 with the support of Pasteur Network, and also with the support of WHO offices. It was in Lyon in France, really involved in capacity building. So we started to train people from 2006 to 2011 with the support of many experts. So I think you can see Françoise was here. Françoise was with us in 2006, the first one, and also in 2007. You can see Françoise here. You can see a young Laurent Massolier there. And we continue, and in 2011, Caroline Lavender joined us. Caroline, you are here. This is Myriam, Estelle Marion, Laurent Massolier. So many experts come and join us to help us train other African laboratory. So this is some few pictures we were training. So for all diagnosis from microscopy to Lowenstein-Jensen major for culture. We were training for classical PCR first, but then we moved to qPCR. The year after, we also include collecting samples on the field to train also people to increase their capacity to organize. At this time, there was many studies on the transmission of Buruli ulcer. So we built really this capacity during four sessions, I think, and for 11 countries. And the aim was to build a network with people from Ivory Coast and DRC. We tried to get funds to build a network, but we didn't get funds. So, but our training facilitated the introduction of molecular diagnosis in other African countries, and based on the AQA implementation by the supra-reference laboratory, many of those countries starting doing external quality assurance control. So you can see the list of some of the laboratory in the acknowledgement of this paper from Miriam. But during the last AQA in 2018, so the conclusion from the SRL was that the overall AQA results showed that the median performance of participating laboratories improved laboratory over the 4 rounds. However, the proportion of laboratories reporting false positive and false negative cases remains high, thus flagging both the quality of data reported by the WHO in Africa and the result of studies carried out in these different laboratories in various countries. So that was there was a question of the accuracy of the results reported from Africa at that time, and ITM Antwerp decided to stop the AQA program. So WHO decided to continue the AQA program with a volunteer lab, and the lab who had good performance during this AQA. So we have chosen to continue this activity, so the dream become true, and we're able to organize a network at this time. And based on these comments, we were thinking how to exactly improve the quality of those labs. So the only way we were thinking is to harmonize. You can only do same thing to get comparable results, and to be sure that if there is an issue or false results, you can help to resolve the issue if you know exactly what was doing in the lab. Because during the past AQA, each of the labs were doing, some were doing real-time PCR, others were doing classical PCR, so it was not easy to compare the result. So in 2009, in 2008, so in 2019, we were able, with the support of WHO, to build the network, to have our first meeting. So later on, the program manager of the BU LabNet will do the presentation on the processing of how we process to harmonize. He will give details on that. So we create this network in 2019 with the aim to harmonize our procedure, capacity building, and then implementing this AQA to get these comparable results and to give more accuracy, good quality of recorded results. So after these 4 years, now the last step is based on our experience from WHO Buruli Ulcer Laboratory Network. We are moving to improve also skin entities. As I said earlier, for Buruli Ulcer Laboratory Network, we were able to harmonize our qPCR-based diagnosis. We develop and implement AQA. Also, we get expert visit on the field, so we assess all the capacity of the lab involved in the. And now we are also working to explore how we can implement collaborative research through the world also to support this capacity. So we are now expanding to the WHO skin entities. That is the new website built with WHO. We are working on that. And there are new labs we will be including, so the transition will be to also harmonize SOP for YOS, for leprosy, for mycetoma, and also for cutaneous leishmaniasis. So we have other WHO Collaborating Centre working with us. We do not have all the expertise, so many experts are joining us to help us on this harmonization. Why are we harmonizing? So it's really to not multiply platform of diagnosis in Africa, but we have to see how we can integrate. You know, the number of cases is decreasing. So we would like to integrate other the diagnosis in the same platform. And the harmonization now is trying to use the same reagents as possible that the one we are using for Buruli ulcer. So we have already we done the evaluation for use. It's working now. It's under validation to WHO. We did same for leprosy. It's working with the same reagents. So with the support of Spain, they are working on leishmaniasis, and we have Wendy who is working also on mycetoma to see how we can reduce the number of reagents, and also how we can have also some reagents we can have at the room temperature. This will really ease, make it more affordable and ease the transfer and the shipment of these reagents. So for the future step, we need to continue to addressing the gaps at the level of the lab and see how we can continue to improve access through training, through funding, and also partnership. So there's a good example of how to have a friendly and transportable tools in the field, like GenSpire. So our dream is to have something we can just put the cartridges and have the results. But having this in mind, we have already started to evaluate the BioMIM. BioMIM is also a mobile qPCR, and we did the first evaluation on the field comparing what we can have for with BioMIM to what we're having with the qPCR, and the results are really comparable. And now we have an ongoing project with American Leprosy Mission and ANESVAD to develop and evaluate this BioMIM qPCR assay with multiplex, so used for the diagnosis of the 5 skin entities. This project is still ongoing on, and we have also to keep in mind other published results, like the using of isothermal recombination published by Professor Phillips' lab too. So we are trying to address this gap to have more accessible food. And in this future, also in this future step, we are also looking for, we are open to all innovation. So more and more we are talking about whole genome sequencing. We are talking about metagenomics. We know that currently it is more at the level of research, but we can also see how we can apply. Okay, I finished. Also, we can apply on that. We were thinking also, you know, we have microscopy, how EI can also help us to improve microscopy on the field. So we really think that the innovation step toward bridging this gap between laboratory efficacy and field is our next step. So the way forward is to continue to see how we can use this molecular diagnosis and also look for innovation solution. Future action, we continue to collaborate, build capacity, and also we call for action, this continuation of research, and also it's really necessary to continue to move forward. So it is time, but thank you very much. Merci beaucoup. For all the member laboratory first, they really come in, give the procedure. We were able to evaluate, compare, and we were all open-minded to choose only one procedure. Thanks to all international labs, we are now participating to the AQA. This gives more value and visibility on that. We have all experts working with us, all the team. So still as we started, ALM came in to support the coordination of the network. Raul Fulero was able to buy all the reagents to help us do harmonization on AQA, and as well support meeting, building capacity on the field and so on. And thank you. This is all through WHO support. Thank you very much.
I'm not sure why the microphone is, but we can take two questions. Two questions for Sarah, if they are. Yes? One there. Yeah, you can.
Just start my question. Hopefully my voice is enough.
For the webinar, yeah.
Thank you. Thank you for this wonderful presentation. My question, myself Pranab, I'm doing my PhD at Dakin and Cairo. My question is, what is the sensitivity and specificity? I mean, for the field qPCR you are using about the multiplex PCR, or is it better to use the single field qPCR for instead of the multiplex one?
So the complex, the implementation of the complex or the multiplex PCR is still going on. It is not the one we are using. We are using classical we are using qPCR now for one of each of the diseases, but the work to make complex multiplex is still going on.
That makes sense. Thank you.
Perhaps my presentation was not clear, but it's still
yeah,
going on. Multiplexing is still going on using the BIMIM, the mobile qPCR. That is supported by ANESVAD and ALM.
Yeah, thank you.
Okay.
Any other? Do you have any other questions? All right, Sarah.
Okay, thank you very much.
Let's give it up for Sarah. She and her team, they really do a great job in keeping all of us in check. And when they want their results, trust me, they can be a pain in some way. But thank you, Sarah. Our next speaker, somebody who I always look at with a keen eye from afar, and I listen to him intently when he speaks. He will be speaking to us on the work of the WHO Diagnostic and Technical Advisory Group on skin NTDs. So Gert Pluska, Professor Gert Pluska is the head of Molecular Immunology Group at the Swiss Tropical and Public Health Institute. I knew they were in Basel, but I see now they are in Aarschot. Hope I pronounced it well. He studied biochemistry and has worked at the Max Planck Institute for Molecular Genetics in Berlin, the Basel Institute for Immunology and Cyber Pharma Research before joining the Swiss Tropical Institute in '95. His work is focused on the analysis of host pathogen interactions and the development of new tools for control of tropical infectious diseases. Research projects include molecular epidemiologic studies on the dynamics of bacterial meningitis in sub-Saharan Africa, studies on host cell invasion in malaria vaccine design, and the development of new diagnostic tools and treatment modalities for Buruli ulcer disease. Professor Gert Pluska, kindly let's welcome him on stage with a clap. Gert.
Good morning. After a discussion with Sarah, we decided that we both change the title of our presentation. So I will focus on the development and strategies for the development of rapid diagnostic tests. So be ready for 15 minutes of suffering. But maybe in the end we will end up there. And it's very clear that the introduction of the diagnostic PCR is one of the milestones in control of Buruli ulcer, and it's wonderful to hear now that it's implemented in the endemic countries and the shipment of samples to Europe or the US is no longer necessary. But I think we also agree that it would be very nice to have a point of care test, which you could use at the primary health care level, at health posts, or even directly at communities, so that the surveillance team could go into an endemic community and immediately do the test. For the molecular test, there are a couple of approaches to make it more field compatible. And in fact, there's one approach which is integrating all the steps of a PCR in a cartridge. We don't have this for Buruli ulcer. It was initially introduced for tuberculosis, and it may have a bit of problem with this point here of affordability. And what's much more common is to use other strategies for a point-of-care test, and let's look into this. The initial work was focused on serology, which makes a lot of sense. That's working for many infectious diseases. And it was then soon recognized that there's an enormous cross-reactivity between mycobacterial antigens. So in a population which has exposure to many environmental mycobacteria and which is BCG vaccinated, it's very hard to find a suitable antigen. And here we have one of the examples where genomics has helped a lot. Tim has identified a set of Mycobacterium ulcerans specific proteins, and some of them were in fact immunogenic enough to see a response. But the disappointing point was that there was no differentiation between patients and healthy individuals living in the same endemic environment. And we had the same experience with a small heat shock protein, which is overexpressed in Mycobacterium ulcerans, therefore relatively specific. We also saw that patients and healthy controls both show in a high proportion antibody responses against this protein. The interpretation is that many more people are exposed and develop disease, which is not uncommon for other mycobacterial infections. East African sera were negative, and this tells us that maybe such an assay could be useful for seroepidemiology and identifying endemic areas. How about other antigens? And then, of course, mycolactone is a top candidate as a specific for Mycobacterium ulcerans, but it's a relatively small antigen, and when it's not covalently bound to a carrier protein, these small antigens often don't produce significant antibody responses. And in that sense, it's not surprising. We've tested a lot of patient sera and sera from healthy people in endemic communities, and we haven't found evidence of natural immune responses against mycolactone. And finally, there were also ideas to develop a T-cell assay similar to what is developed for TB diagnosis, interferon gamma release assays. And here, the surprising thing was that the classical strains found in Africa and Australia have no deleted in or have pseudogenes in the course of their genome reduction. So one cannot just transfer this for Buruli ulcer. And it's also an interesting aspect, maybe that's part of immune evasion of this microorganism during evolution. So I'm afraid measuring immune responses to the infection is not very helpful. And then we have the other option to detect antigen. And that looks much more promising. Yeah, we have a functional assay which is clinically evaluated, and this is the thin layer chromatography detection of mycolactone. And I think Kishi introduced this very elegant method of specific labeling. So there's a diol in the long chain, and this is binding to aromatic boronic acid, and this enhances the immunofluorescence enormously. So you can then detect mycolactone specifically on the thin layer. It has reasonable sensitivity and specificity. There are still some challenges. There's still space for improvement. But the downside is you have to extract mycolactone, the lipids, And the thin layer chromatography is not something you would do at community level. So it's rather a test for hospital settings with a laboratory. Then the other option for mycolactone would be an immunological assay, and this was hampered for a long time that we didn't have reagents binding to mycolactone. Remember, if you inject mycolactone into animals, you don't get an immune response. And here, a colleague from ETH Zurich has helped us producing these synthetic molecules, replacing the upper chain or the lower chain with a linker, which can be used to bind it to a carrier protein. That way, you get very nice immune responses, either against the more hydrophilic or hydrophobic part of the molecule. You can produce monoclonal antibodies and test these monoclonal antibodies for detection and for RDT development. And out of larger set of antibodies, one was outstanding in performance with a competition assay. In this assay, you use a synthetic mycolactone, which gives a signal. So you have a signal when there's no mycolactone, and if a sample has mycolactone, then the signal is going down, and the mycolactone is competing with the reporter. We have tried to convert this ELISA into a lateral flow assay with a Californian company, DDTD, providing antibodies and discussing the reaction conditions. This RDT works nicely if you have synthetic mycolactone in a buffer, but it has poor performance, unfortunately, when you go with clinical samples. And one reason for that is that mycolactone is a pain to work with. It is not nicely soluble, but it forms micelles. If you have serum proteins in wound exudate, it associates with proteins, which reduces the availability. You could do extraction, but then you don't have any longer a very simple test. And it likes to bind to one specifically to all kinds of surfaces, including like the nitrocellulose membranes used for the RDTs for the lateral flow assays. Another disadvantage of this first test format is that you have a band, and the disappearance of the band shows that you have mycolactone. That can be very confusing for a clinician who is used to the vice versa situation, and that's why it's not the best format. And so François said we shouldn't give up too early. So we haven't given up. We go for an alternative, which is an antigen capture format, and we try to avoid the lateral flow membrane. So the capture assay, which was actually developed by Luisa, she's sitting there, and will give a talk this afternoon on drug screening. It employs two antibodies. So one, you bind to a surface, then you add the sample, the mycolactone is captured, you come with a second antibody, and this combination of two antibodies, two specific antibodies, makes such assays highly specific. And what we are trying is now to convert this ELISA format together with colleagues at ETH Zurich, now not in a lateral flow assay, but in a microfluidic assay where you don't have these membranes which may capture unspecifically mycolactone. Still have one other option, and Katherine Röttgen presented these data before. We have identified a particular protein which is suitable for a rapid diagnostic test, which can be nicely extracted from the surface of the bacteria. It's again antigen capture assay, so we have excellent specificity. PCR negative samples are negative, and we have limited sensitivity. So if you have a lot of mycobacteria in your sample, a low CT value in PCR, you get positives, but when there's very few bacteria, it's negative. We've tried to develop an RDT together with Alir based on this assay, and we didn't gain sufficient sensitivity, but the technologies are moving, and here again we are currently working with ETH Zurich on a different detection system, electrochemical detection system, and we hope that this way we can improve the sensitivity substantially. So basically we have two approaches at the moment still running. It will take still some time to optimize and then to validate, but I can tell Françoise we haven't given up too early. Thank you very much for your attention.
Thank you very much, Gerd. You saved us some time, so we can take some questions. Yes, at the back. Israel.
Thank you very much for your presentation. I would like to ask you and maybe others in the audience about the interest of pursuing antibody detection tests. I know it's not the ideal approach, but there are many diseases in which we still use antibody detection tests combined with a good case definition. And given that the Buruli ulcer score performs good, if we try to pursue antibody detection test, maybe it's a more easy approach, or we can get faster to an RTT. It's less complex.
Yeah, if you can raise your voice when you are speaking, so that those on the webinar can.
Oh, sorry.
No breakfast today.
That's all right. Yeah, you read that.
Yeah, so all the experience we have, I'm very pessimistic that this can be helpful, and I would definitely rather go for antigen detection, whatever antigen it is.
Right. Any others? Yes, Paul. Baka, you have the microphone, then Paul will follow after you.
Very nice talk, Gert. On this serosurveillance that you mentioned with HSP18, is that being applied? And thinking of Kingsley's presentation, where when the numbers decline, in some countries we know people are still actively looking for Buruli, but if the numbers decline, we don't know, is it really a declining incidence or did we stop looking? And doing serosurveillance for HSP18, could that be a solution to see where should we look more consistently, whether there are cases that we're missing?
Yeah, there may be the problem that you have to think a bit long term. So if the incidence of contact with the bacteria is going down, your serum response will still be there for some time, and maybe it's declining substantially, but you still may have some booster effects. So I'm a bit skeptical whether you can trace something unless you have a program financed for 20 years. And on the other hand, I didn't go into that. We for example, had samples from a region from Ghana which had the reputation not to be a Buruli endemic. We found one outlier. This patient was revisited and actually had a Buruli wound which was not recognized, PCR reconfirmed. So, and we have done a bit similar things to go in certain region and have a look whether we find titers like that. So I think that's maybe the more promising application, rather than looking into these intervals and changes in incidence.
All right. Yeah, Paul.
Thanks, Gerd,
Sorry, not yet. Paul has one.
for a fantastic presentation. With your the capture,
Not Paul again. Oh.
with the Mycobacterium capture system, you're ending up with a microfluidics approach to getting a field test. That's starting to look a little bit like the Gene Expert again. So in terms of, will that push the cost beyond what's
No,
practical?
there are now microfluidic systems which are roughly in the same range, cost range as lateral flow assays. You may need a small device for the detection, but there are very cheap ones now also. It will be a little bit more expensive, but I think not dramatically.
Right. Yes, one last question. Oh, it's been asked. Okay. All right. That saves you. Gerd. Let's give it for Gerd again. Very eloquent speaker, and my hope as a clinician on the field is that you give us not a Rolls Royce, but a Tesla-based test before you finally call it on us. Our next speaker, there's been this time not a change in topic, but a change in speaker. Elena Dakal is from the International Health Department at the National School of Public Health, Instituto de Salud Carlos III. I'm not a Spanish speaker, but I hope I tried. And she's interested in innovations and implementation research to improve access to care for skin NTDs. And she is a member of the Operational Research and AI groups at the WHO Collaborating Centre for Leishmaniasis in Spain. Elena. And we welcome Elena. She's speaking to us on modeling of Buruli ulcer.
Thanks for the introduction and also for having the opportunity to be here presenting our preliminary results in this project. My talk is titled Modeling of Buruli Ulcer, Guiding Efforts Towards 2021-2030 NTDs Roadmap Goals. And just as a brief introduction of what is the motivation behind of this project, so we have developed a model that is aligned of the WHO NTD roadmap, and more specifically with the first objective of the reduction of the proportion of cases in category 3 at diagnosis than less than the 10% by 2030. And although our model is tried to be universal and can be extended to other regions and countries, we first contextualize it in Benin due to the high impact, as most of the cases occurs in high-risk African countries. So based on that, we have developed a dynamic model based on the natural history of Buruli ulcer. And here is like a theoretical representation of this model. As you can see, we have divided the disease in 3 categories, as WHO represented the severity of the disease. And here we have assumed that without treatment, the disease can progress from category 1 to category 3. Then we have 3 transitory states as a result of diagnosis and treatment of each category. And finally, we have 3 terminal states. One is the permanent disability as the progression of the disease without treatment, and 2, which is the patient can be healed with or without disability. The activities for diagnosis and treatment in each category are case finding, diagnosis, antibiotic treatment, wound care, and prevention of disability. And these activities have different ways depending on the category lesions. So we have developed this model in Benzing, which is a software program that allows us to build, analyze, and visualize the results of these dynamic models. And here I will try to explain a little bit how this model works. So you can see the 3 categories of the lesions, the 3 categories of diagnosis and treatment, and also the 3 terminal states. Basically, the transition between the different states, not only for the categories, but also for diagnosis and treatment, is controlled by a flow system, and this acts like a tap system So it's easy because the hand that opens or closes the tab system is the resources designated for diagnosis and treatment in its category. So I think that it makes sense if we increase the resources for diagnosis and treatment in category 1. So if we open these tabs, for example, in category 1, the flow of patients that progress from category 1 to category 2 is going to decrease, and this flow is going to increase. So this kind of models allows us to assess the impact of the different resources allocation. So behind of these flows, there is a mathematical formula that is depending on different parameters, and here you have a description of them. For example, the average time of the patients in category 1 without interventions. So to initiate the model, we need to give some values of these parameters, and here is an estimation. We obtain this information from our teams in Benin, but we can modify this data according to the context. So here you can see the estimation for all of these parameters. And once we have developed the AI model and to establish the parameters, we can simulate different scenarios with different resource allocations. And here is just an example to demonstrate if the model as we build is working or not. So as an example, we propose for easy scenarios. The first one is no treatment scenario. So we are going to recreate the natural history of the disease without resources for diagnosis and treatment in its category. The second scenario is when we increase these strategies for category 1, the third scenario for category 2, and the last scenario increase for category 1 and category 2. So as you can see here in the table, and if you have in mind our objective to evaluate what is the best strategy to reduce the proportion of cases in category 3, as you can see, the less number of cases we obtain the less number of cases in category 3 when we increase the resources for diagnosis and treatment in category 1 and 2. That makes sense, but if we want to compare or to choose if it's better to diagnose and treatment between category 1 and 2, the best strategy is to increase the resources for category 2. This is only an example to show the functionality of the model. So the next step is that we translate this model to the Python language, and we create a website to have a more user-friendly tool and also a little bit more complex. Here there is a video demonstration on how this website works. At this moment we are translated into English and other languages, but if anyone has interest to enter into the websites, you can let us know and we will try to create an user, and it will be a very nice opportunity to have your feedback also. So basically, in this website, you have the opportunity to create new simulations with using the default settings for the parameters as we saw before, but you also can create new simulations with different parameters. And here there is an example with a simulation with default configuration. As you are going to see now, we have the predefined parameters and also at the predefined cost. So we are only going to modify the initial resources for this diagnosis and treatment category 1, 2, and 3, and this is like a random example, and also you can enter the annual cases in your situation and modify the simulation days. And now with these parameters, you can see the number of people in each stage for category lesions, but also in treatments and the final states. And we have here a simulation of the detection codes. It's very simple. And you can see these results in a graph mode to give another experience. So now, and also I think that here, yes, you can create different simulations and compare between the different simulations to share with other colleagues, to have their opinion. So, oops. So now the next steps is we want to incorporate a more accurate cost analysis, because it was very basically in the website that you saw, for diagnosis, treatment and care for Buruli ulcer in Benin, not only to complement this natural history model, but also to assess also the impact and cost effectiveness of other strategies. For example, for the clinical trial, BLMs for Buruli ulcer, which is a project funded by ANESBAT and Raúl Fulero Foundation and coordinated by the University of Zaragoza. And today I know that you are going to have the opportunity to know more in depth this clinical trial. So as a conclusion, we have developed a Bayesian model that we think that can contribute to define strategies for controlling Buruli ulcer. This is a preliminary results because, as you saw, the condition of the scenarios are very easy, but in the short term, we saw that, and without accurate diagnosis tools, the most interesting approach is to increase efforts to focus on cases with category 2 lesions, but the next step is to pilot with actual data and also incorporate cost components to evaluate the effectiveness of the different strategies. So last, I am here on behalf of a great team in Benin and in Spain, so I would like to thank all of people who is involved in this project, especially to Isra Cruz, who is also in this room, that coordinates the project and also supervises me. So thank you so much for your attention. I'm happy for any questions or suggestions.
No, thank you for this talk, and especially for this approach of measuring the cost effectiveness of, or the cost associated with the treatment of Buruli ulcer. And this is really the communication tool that we can use to show, I mean, actually this can be the only kind of the tool that we can show actually the impact of the disease to the patient and to the society. So, excellent approach. My question is the parameters that you used. It's based on literature and expert opinions, or I'm not sure how evidence-based this is, because what you identify as the parameter really identifies how the model works. And for category 3, you had 180 days, 6 months of treatment. I think this is kind of underestimation of the reality. So just how evidence-based this is. And also your kind of division for how you can apply this beyond Benin is my second question.
Yes, so here the numbers is, as I said before, is like a preliminary estimation based on the experience of our team in Benin. So you don't have to take into account as a must, because it can be modified, and also depending on the context, not only the country and also the time. So yeah, essentially, probably this is not working for all of the context and for all of the moments, depending on the context, but yes, it's like an estimation. And what's your second question, sorry? I don't know.
How you're planning, are you any vision of applying this to countries beyond Benin?
Okay.
So I think this needs to be more country-specific tool, because the situation changes across countries. So how you can apply to different countries?
Yes, I think that is not only country-specific, because also inside of a country, the conditions can be different for all of the sites. So yes, the idea is that to have a universal tool, but you can modify the key parameters to do it like an independent tool for not only for each country, but for each situation or for more specific. Do you think that it makes sense, or do you think that there is another approach that it will be more interesting?
I think the country-specific is still, it's good, because that's what the countries need. And so, yeah, thank you for the excellent approach.
Thank you so much. Thank you.
Thanks so much, Elena. That's wonderful. Thank you. Good morning, everyone. My name's Katherine. I'm a local clinician, and my role here is mostly to support the scientific expertise at the reference lab. So I'm very happy to be co-chairing this diagnostic session. We'll just, I'll jump ahead your slides. That's all right, Elena. All right, so it's my pleasure to introduce Mr. Hyacinth Nkrumah, who's at the Centre Pasteur de Cameroon. Nkrumah is a microbiologist working on the Buruli ulcer diagnostics for the past 5 years. In parallel, he serves as the program manager of the WHO Skin Neglected Tropical Diseases Laboratory Network for Africa, hosted at the Pasteur Centre in Cameroon. In addition, he has over 8 years previous experience working on the tuberculosis diagnostics and was formerly the National Laboratory Coordinator for the TB Speed Unitaid project on paediatric tuberculosis implementation in Cameroon. His areas of interest include molecular diagnostics, mycobacteriology and lab quality management systems, and we were very happy to be part of the EQA program that he was part of, and we were also very happy to get good results. Thank you very much, Nkrumah.
Thank you very much for the kind introduction. Good morning, everybody. I'm quite excited to be here today on behalf of the team to share our experience on the work we carried out harmonizing Buruli ulcer PCR diagnostic procedures across some laboratories in Africa. Now, in the diagnostic context, the goal of harmonization is to ensure that results generated by different laboratories diagnosing the same disease is comparable. And from literature, we have seen that harmonization has the potential of resolving issues in the variability of test methods, thereby enhancing the quality of diagnostics, which then translates to improved patient outcomes and reliable surveillance data. Now, amongst other factors, the decline in the BU PCR confirmation rate by most African countries over the years has been attributed to these differences in diagnostic procedures, and this has led to the increasing need to harmonize. One of what prompted WHO in 2019 to bring together a group of 12 laboratories from 9 African countries to form a network which has already been described by Dr. Sarah Yango. But then I would still repeat that the network is hosted at the Pasteur Centre in Cameroon because I work there, and generously supported by the American Leprosy Missions, the Raoul Folero and Anisbat Foundations, of course with WHO providing the overarching leadership. Now that the network was formed, it was time to proceed with the harmonization work. So the first thing we did was to collect BU PCR procedures from these network labs, procedures which included DNA extraction, the real-time PCR, including the master mixes, the primers of the probes, and the DNA standard. Once in possession of these SOPs, we performed a comparative evaluation based on sensitivity and specificity of the test methods. We also looked at feasibility, robustness, and cost. Basically, what we did is, amongst the varied procedures used by the labs, we narrowed down to select 2 of each method, which we evaluated using swabs and finding the aspirate samples of known M. ulcerans concentrations. We then went further to adopt one of these methods, which we validated for use by the labs. So for the DNA extraction method, we selected the alkaline lysis method, which we know to be rapid, cheap, and sustainable. For the master mix, the idea here was to select one which is compatible to all thermal cyclers and which could be shipped at room temperature. So from a comparative analysis, from literature review, we stumbled on the Brilliant 2 and the Hot Fire Pole Probe master mix for evaluation. We did the same thing by selecting 2 sets of the primers and the probes. And of course, for the DNA standard, we selected the M. ulcerans infected mouse tail and the DNA plasmid. So with these, we performed the PCR tests using the DNA extraction methods. The PCRs, we used the primers and the probes, and then we did other tests with the DNA standards. And what we obtained as results from evaluation of the extraction methods, we didn't find any significant difference between these methods, so we adopted the generalized method. And to validate this, we further tested with additional BU positive samples, and still we had no difference in the results obtained. So we settled at the generalized method for use by the labs. Now, both master mixes were compared or tested in parallel with the primers of the probe set, and we found similar results. However, we adopted the hot fire pole master mix, since we know that it's guaranteed to be stable or more stable for a longer period of time. And for the primer and the probe, we adopted set 2, which was described by 5 and colleagues in 2007. Finally, for DNA quantification, we adopted the plasmid DNA, since it's known to be commercially available. Now the story didn't end here. The next thing we had to do was to develop the standard operating procedures. And to note, in addition to the DNA extraction and the real-time PCR, we also, together with the labs, harmonized sample collection and processing, giving all together 4 standard operating procedures which were approved and distributed to the labs. You can find these procedures on our network. So the labs were required to use these procedures for routine testing and also to implement the external quality assessment program. Now, from 2020, we have been collecting workload data from these labs, and you can see the trend from that time up to the first half of 2024. But please don't ask me why the curve has been going down from 2022. And we are thrilled to share with you that for the EQA, we have had an increase in the laboratory performance over the 3 conducted rounds, demonstrating, I would say, a successful harmonization intervention. And we are also glad to share with you that other non-member labs participated in this EQA, especially the one-time EQA organizers in Belgium. We also had a lab in Germany, Spain, and also some labs here in Australia with an overall excellent performance. Now, we didn't go through this process without some challenges, or let me say limitations, one of which was the differences in the infrastructure, the lab space, and existing resources in these labs, which we had no control over. Also, in as much as we expected these labs to use the same procedures for testing, the same labs had different molecular diagnostic platforms with possible differences in sensitivity, which, of course, we couldn't control. Another factor also was the varying levels of training and competency of the lab staff at the initial implementation of the SOPs. Now, as we heard already, we have moved from the BU LabNet, and we are now the Skin Entity LabNet. And based on our experience, we look forward, or we envisage, including additional labs in the network and to expand the harmonization initiative. And also, we look forward to getting our intervention serve as a model for other neglected tropical diseases. Now, in summary, we are glad to have been able to harmonize our BU PCR procedures. And in addition to the EQA, it really helped the labs to improve on their diagnostic performance. And also we've seen that implementing the harmonization is essential because it results to more reliable research data and, of course, improved disease control and surveillance. And last but not the least, we see that the harmonization intervention is critical to ensuring a more effective and data-driven policy making. And in our case, our work aligns with the WHO roadmap for neglected tropical diseases. Now, this work wouldn't have been a success without the contribution of all the member laboratories, the affiliated labs, our partners, and the national disease control programs. We would not end without appreciating Tim and his team for the wonderful organization and the opportunity for letting us do this. And for all of you in the building, thank you very much for listening.
Thank you very much. Do we have any questions? I guess I have a brief one. The labs are doing wonderfully well and the improvement's lovely to see. For those labs that do fail, is there any follow-up program or support to help them improve their performance over time?
Thank you very much for the question. I would not like to use the word fail, but the labs that have low performance, or unsatisfactory. Yes, so for labs whose results were unsatisfactory, we actually carried out an online troubleshooting, which also involved preparing newly fresh PT samples, and we sent to these labs. And we've also had experience that when this was done, the labs sent back results which were 100%.
Yeah, great.
Yeah, right.
Wonderful. Yeah.
Yes, so thank you. I'm happy to hear about all the development around the skin NTD.
I'm sorry, I
.NET.
didn't get you.
No, I'm glad to hear about all the development around the skin NTD, .NET. My question is about, we are hearing about the PCR and the methodologies, but what is happening for the capacity building and the training, and how the BU, well, now the skin NTD.NET is trying to contribute in the capacity building of the lab personnels? Like for PCR methods, even like microscopy, is there any kind of the vision for providing trainings?
Thank you for the question. Please, I would like you to kindly send the microphone to Dr. Sarah for a response next.
Okay, thank you for the question. I think it was about capacity building, what we are doing on capacity building for this lab. So first of all, what we are doing is to assess. We build an online assessment document, so they have to fill the document. And with the support of ANESVAT, we can visit the lab on the field and see how we can directly support them. From one lab to another one, the needs are not really the same. But for capacity building, we are more talking about training, because till now we cannot help them for equipment or other infrastructure. So we are trying to have all technicians able to correctly do the work. We can send on-site training, or we can send the technician to another lab. So we get some technician coming in our lab to train them. But we can, if there is an issue on the site, we can also send someone, another expert. We are many of us, not only at the level of the coordinating center, but other experts are able to go to the field and support the lab. So capacity building is more on training, to be sure that they are able to implement successfully the SOP. Is it okay? Thank you.
Thank you, Sarah. Thank you. We might leave it there. Thanks very much. Okay. Our next speaker is Mr. Navin Karan. Navin, where are you? Yep, excellent. Navin is a senior medical scientist as well as our training and capacity manager at VIDRL, the Victorian Infectious Diseases Reference Laboratory. He's currently a co-lead of the public health cross-cutting discipline at the Doherty Institute. Navin has extensive experience working in developing nations, strengthening laboratory systems to improve diagnostic and public health surveillances through provision of technical training and advice to regional agencies, partner organisations and in-country ministries of health. Navin is an expert advisor on laboratory systems and capacity building for the Asia-Pacific region. I think that's what he's going to talk to us about today. Thanks, Navin.
Thanks, Katherine, and good morning, everyone in Bula Vinaka. It's really nice to be here. I'm just going to give you a brief landscape on actually Mycobacterium, not necessarily ulcerans, and diagnostic capacity in the South Pacific region, which also covers some of the North Pacific Island countries as well. As you know, and we have seen over the last couple of days, that ulcerans really is not an issue in most of the Pacific Island countries. It's only PNG that have been reporting, but haven't been since 2019. So hopefully this is enlightening. This is almost like a storytelling of our region in the small island country states that we have next to us as our neighbours. So just to give you a quick, I'll give you a quick, I guess a map. I'll show you a map about the South Pacific region and the countries that are in it. The overall laboratory services, just as an overview, and how that's organized in each of these countries. A diagnostic human health laboratory capacity summary as well, some Mycobacterium referral pathways, some of the Mycobacterium cases, as well as some cases of ulcerans from PNG, and some future strategies that we can employ from our reference laboratory, etc., to support PNG and others in the region. So just to highlighting this map to you, just to demonstrate how diverse the Pacific Island countries are. They're small islands, if you like, that don't share land borders at all, apart from PNG. And covering about 17 Pacific Island countries in this talk, so all the way from American Samoa, Cook Islands, Fiji, Kiribati, Marshall Islands, FSM, which has 4 different states as well. Nauru, Niue, CNMI, Palau, PNG, Samoa, Solomon Islands, Tokelau, Tonga, Tuvalu, and Vanuatu. I'm leaving out the French Polynesia in this, Pitcairn Islands, as well as Wallis and Futuna and New Caledonia, as they're French territories, and I don't really work with them as much. So the laboratory services and the way they are set up in the region and in each of the small island country states are very much centered around the hospital services, like we are as well around the world. The clinical laboratories are primarily part of government hospitals. There are some private sectors as well, so they're privatization of hospitals and privatization of laboratories that do exist, but they're quite small and not necessarily well regulated. Countries in the region have tiered healthcare system, so some larger countries like PNG, Fiji, Vanuatu, Solomon Islands, etc. have multiple major hospitals with 4 and 5 levels, and they're generally divvied up into central or national public health lab that might exist, and that does exist in PNG and Fiji. We've got divisional or regional or general hospitals, followed by subdivisional or district provincial hospitals, health centers, nursing stations, and so I've just listed some of the other countries that do have that there. Major hospitals that have traditional laboratory sections, so they range from our reception to phlebotomy, biochemistry, a hematology section, microbiology section, often divided up into TB, and a media room as well, because they make in-house medias mostly, blood donor, transfusion section, and a serology section, and some labs have anatomical pathology and cytology. So the ones that are highlighted in pink are the ones that exist in almost all the settings, but the ones that are sort of like not highlighted exist in like major hospitals. And in terms of the diagnostic laboratory capability in the Pacific region, so it does vary, because you're looking at population in Niue, which is 1,500, to populations in PNG, which is about 17 million people. We do have some open RT-PCR platforms in the region, and that sort of increased rapidly during the COVID-19 period. As such capacity building, so Cooks, Fiji, Guam, Kiribati, CNMI, Palau, PNG, Solomons, Tonga, Vanuatu, and I've got Samoa and Tuvalu in brackets because they do have CFX96s, so our qPCR capability, but hasn't been implemented to be functional yet for any diagnostic assays. And prior to SARS-CoV-2, for example, for the outbreak, only Fiji had PCR capability in that list. So the capacities for microbiology itself include basic microbiology instruments like microscopes, incubators, in-house media making capability, use of human blood to make that media, manual identification and AST testing for majority of the sites. Most of them now do have blood culture machines, which is fantastic. There's others that also have Vitek too, and BD Phoenix, so Fiji, American Samoa, CNMI, and the Marshall Islands, and Samoa have the BD Phoenix as well for their some semi-automation in that space. In the Pacific, we do have a very strong laboratory network. It's mostly, it was developed, the PPHSN network, I should start, sorry, which is the Pacific Public Health Surveillance Network that was developed in introduced in 1998 under the auspices of WHO and the Pacific community. And part of that laboratory network was formed to combine all the Pacific Island countries to talk to each other, harmonize some of their practices, etc. And priority pathogens are defined by the PPHSN, so there's ongoing surveillance or syndromic surveillance and a weekly report that you can receive as well on the 7 or 8 different pathogens that I've listed there. And you can see in terms of neglected tropical diseases, you've got dengue, I guess, in it, but there's not very many others that are really covered in that priority pathogen reporting. And generally, most of the sites in the Pacific Island countries, they report through the early warning alert response systems that is then collated by WHO and reported out of the Fiji office. And in terms of the Mycobacterium diagnostic capability, so we've got only 2 sites that have a PC-III facility, and that's in Papua New Guinea and Fiji. Unfortunately, both are down right now. The PC-III facilities are failed. They're waiting on external expertise to come in and do some of the engineering assessments as well to understand what could be done to the HVAC systems. But it mostly and almost all the sites do have an AFB smear that their staff are trained to do Zell-Nielsen stain and interpretation of AFBs. Gene expert do exist quite widely, like Fiji, for example, has about 56 gene expert machines, and about 10 of them, I think, are 16 module ones. And the common specimen types that they receive range from sputum, aspirate biopsies, tissues for TB diagnosis, and some pus swabs as well, I'm told, in PNG, purely because of the ulcerans issue. And I've mentioned the 10 countries that do have open RT-PCR platforms. So when if for Mycobacterium, if it's AFB positive and it's gene expert positive, for example, on the gene expert ultra cartridge, they have a strong referral pathway for sending those isolates off-site for drug testing. And only when it's rifampicin resistant on the gene expert ultra cartridge, I think. So in the Northern Pacific, which is American Samoa, FSM, Marshall Islands, Commonwealth of the Mariana Islands, and Palau, they send their samples to the Diagnostic Laboratory Services in Hawaii. And for the QMRL, which is based in Brisbane, they receive samples from Fiji, Nauru, PNG, and Vanuatu. South Pathology, which is in Adelaide, which is a WHO Supra TB reference lab, they receive samples from Kiribati and Solomon Islands. Up in Lab Plus in Auckland, New Zealand, receive samples from the Cooks, Niue, Samoa, Tonga, and Tuvalu. This network's also meant to support EQAP in these countries as well by doing blind smear testing, so they are meant to send slides back to each of the reference laboratories to get that tested. They also are meant to send EQAP panels to the countries, but that has stopped at the moment. I think I'm told after COVID this hasn't taken off, so I'm going to follow up on it after this, maybe next week if possible. Just to tell you, I know obviously I don't have really much data and stats on Mycobacterium ulcerans, but I do have some on TB, so just to highlight that the labs do and the countries do receive a number of samples and referrals, so they do get a lot of practice in doing AFB smears at least. And ulcerans in the Pacific, as I said, I mentioned, and as we've heard in day 1 and day 2 as well, that PNG stopped reporting in 2019 at all, it's completely. I don't think we haven't received any referral samples from them since then at all at Vidral either. It's something that we must follow up on. And we will. So I thought it was interesting that, in the early days that PNG was reporting a few more cases than we were here in Australia. So future strategies, I guess, for us, like I did some Googling and to understand what it meant in terms of what we have found in Melbourne as well and in Victoria. So PNG has about 6 different ringtail possum species, and the top tip of Solomon Islands, they do have the, the A cuscus, which is a marsupial, or the northern common cuscus or a grey cuscus that do exist on the top of Solomon Islands. The mosquitoes are prevalent everywhere, as you know, and I'm wondering whether we could prove this model in in the field and in these countries near to us. And I guess the future strategies that have been described earlier in our earlier sessions as well as rapid point of care development for neglected tropical diseases. Multiplexing is definitely the way to go, especially in low and poor resource income countries as well. And lateral flow devices, if we can, maybe CRISPR technology is looking to move. Sorry. This is the last slide. CRISPR technology can be moved into lateral flow devices as well, which will be fantastic with its higher sensitivity and specificity. We need to collaborate further with our colleagues in PNG, do a bit more field investigation, look at collaborative grants to work in that space, training and capacity building for medical staff, including detection of case presentations, etc. as well, and incorporating maybe our neglected tropical diseases syndromic surveillance regionally through the PPHSN network that already exists. So massive thank you to my colleagues in the Pacific that have responded to my emails to understand what the diagnostic capabilities are, so which is really fantastic. And I thought I'll just quickly show this slide to Tim and others in the room. But Tim, we do have Dr. Randy, who is a physician working at the Doherty Institute at the moment on a PhD scholar. And he is, like I spoke to him yesterday, it's like I'm speaking to the right person. He said when he was in Daru, which is down there at the bottom, he was diagnosing cases on Mycobacterium ulcerans in 2014, etc., which is interesting because most of the reported cases are from WeWork. So yeah, just leaving it there. Thank you very much for listening to me. Nakavakalevu.
Thanks very much, Naveen. Sounds like we've got some work to do. We might leave it there because we're just running a little bit behind time, if that's okay. And I'll introduce the last speaker. So the last speaker is Dr. Jean Lee. Jean is an infectious diseases physician at Monash Health in Victoria, and she's also an early career researcher with the Stanier and Howden groups here at the Doherty. And she specialises in genomic epidemiology and molecular biology for multi-drug resistant bacteria with a bench-to-bedside approach. Thanks, Jean.
So this is going way, way back to basics, so nothing sort of big picture in this. So we've heard extensively over the last 2 days that Australian native possums are essentially a major reservoir for M. ulcerans. And we know that possum excreta surveys with PCR testing can be used to predict the future risk of Buruli ulcer disease in an area. And this ongoing surveillance is costly. Essentially, in the last year, approximately $23,000 has been spent on just commercial kits to do testing of possum scat. So that led us to then question, okay, can a cost-effective method that's sort of in-house be developed to basically sort of, deal with all of these samples? So before I go through our method, just some background. So humic substances are organic compounds that result from the decomposition of plant and animal residues. It accounts for approximately 75% of the organic substances in most soils. They're yellow to brown in colour, and importantly, have a similar molecular structure to DNA. So when you do a standard DNA extraction, the humic substance get co-purified out. And these actually also then inhibit PCR reactions and other sort of molecular methods. So as you can imagine, if you do a standard DNA extraction on possum scat, you'll end up with a heavily contaminated sample that then inhibits your subsequent testing. Now, flocculants are compounds which essentially cause aggregation and precipitation. So they're used in water treatment as well as mining. And humic substances can be flocculated by aluminium and other metallic cations. So here in these samples, you can basically see an equal amount of possum scat that has been bee-beaten. And in water and 2 sort of aluminium-containing solutions, you can sort of see that with the aluminium-containing solutions, there's been some binding of the humic compounds, which then reduces the amount of humic substances in the sample. Now, for our method, what we essentially did was we pre-treated the possum scat samples with an aluminium ammonium hydrosulfate solution to basically try and bind out those humic compounds. The sample was then subjected to chemical lysis with a GITC solution and then mechanical lysis through bead beating, after which proteins were precipitated and then DNA precipitated, followed by DNA sort of cleanup with a spry bead-based method, after which testing is then performed. Now, to validate this method, we essentially tested 78 possum scat samples. So essentially, the sample was equally halved by weight, with half processed by the in-house method, the other half the commercial kit, which in our case was a QIAGEN PowerSol Pro kit. And then the 2 sort of extracts were then tested by IS-2404 qPCR. So our method was basically found to have a sensitivity of 97.9%, 100% specificity, and only cost 1/6 the price of the PowerSol Pro kit. Now, when you do a direct comparison of the 44 sort of paired samples, which were both positive when tested by the 2 methods, the PowerSol Pro kit was found to be about 3-fold more sensitive, and that was essentially a reflection of the fact that a larger volume is processed with the commercial kit as opposed to the in-house method. So we also adapted our method to process swabs taken from possums. Now, because this specimen type doesn't actually contain humic substances, the aluminium wash step was obviously omitted. And I suppose because this was sort of designed around pre-existing samples, the first step was essentially the carried over step from the QIAGEN blood and tissue kit, which essentially eluted the swab in PBS. I think if you were going to use this method up front, I would actually sort of recommend the inoculation of the swab directly into the lysis solution, so you essentially remove the dilutional effect from the sort of PBS step. And for this particular method, we processed a larger volume of the original sample, essentially because it's a less common sample type, so therefore we didn't require the sort of descaling, or downscaling to sort of, process it at a 96 wall plate as we did for the possum scat method. So for validation, 16 possum swab L08s were tested. It should be noted that actually these were sort of leftover samples from Emma Hobbs' possum survey that we heard about yesterday. So for the gold standard method, essentially samples were tested soon after collection as part of her study, but for testing with the in-house method, it was actually conducted quite some time later, which I think becomes relevant in terms of the sensitivity testing later. So essentially, 1 out of the 11 total positive samples were missed by this method. This was a sample that had a relatively high CT, indicating lower DNA content, which had actually been stored for more than 300 days in just PBS frozen. So I think the odds were sort of slightly against us for sort of having, good sensitivity for that particular sample. However, when we directly compare the CTs between the 2 methods, the sort of spry bead method actually was calculated to be about 4-fold more sensitive, ultimately at only sort of 1/5 the cost of the commercial kit. Now, finally, the method was also adapted to the extraction of genomic DNA from pure mycobacterial cultures. Now, much to my horror, when actually making these slides, I realized that with the recently published manuscript, the volume for the DNA and the spry beads was actually inversed or reversed in the published manuscript. However, what's actually in the text is correct, and what's shown here is correct as well. Now, with regards to input amount, So a heaped 10 microliter loop is what was sort of used in this method. And I think that was initially proposed because I was concerned that the amount of DNA might sort of exceed the binding capacity of the spry beads. Having actually sort of gone through this a few more times, I've actually found that you can essentially comfortably sort of harvest an entire brown and buckle slope without sort of exceeding the capacity of the spry beads, and that then results in a sort of corresponding increase in the DNA yield as well of the final sample. So just for comparisons here, we can kind of see that we've got a number of different mycobacterial cultures that have been extracted with the in-house method. And we can see that there are sort of reasonable yields of DNA with sort of fairly decent sized fragment lengths, and that's despite this method not actually being optimized for sort of long length DNA fragments. And for comparison, at the bottom here we can sort of see the QC metrics of a sort of standard chloroform type extraction, which is what would be more traditionally used for M. ulcerans, as well as what you kind of get if you sort of do a standard sort of commercial kit extraction with a much sort of more friendly to extract bacteria, which is Staph epidermis in this example. Now, the last sort of main thing I should mention is that, so the two main solutions that were used through these methods, so in other words, the GIT lysis solution as well as the spry beads, did interval testing on them, and they were actually both demonstrated to be stable for at least 2.8 years. So I think essentially you can make large batches of these and continue using them over time. You don't sort of need to make things up freshly each time. So in conclusion, we basically have a sort of fast and cost-effective method for the environmental extraction of M. ulcerans DNA, which is adaptable to other sample types with comparable performance to commercial kits. And I think while this was also obviously sort of developed specifically for M. ulcerans, I think essentially sort of, you know, with a different primer probe set, you could potentially sort of use these sort of methods for other sort of testing of other organisms as well. And just to sort of show there's sort of actual cost comparisons, you can sort of see there what the in-house is as compared to sort of two commercial kits. And so finally, I'd like to make the following acknowledgements. That's it.
Thanks very much, Jean. We've probably got time for just one question because we're running a little bit behind, and I'm sure everyone's ready. Paul, it's yours.
Thank you, Jean. When you give those cost comparisons, what do you think about the comparative labour input for the two methods?
So I suppose the commercial method also requires sort of a person to actually go through and literally pipette out everything anyway. So to be honest, it's sort of fairly similar in terms of labour.
Great, that was nice and short. Thanks, Jean. All right, Tim.
Please join me in thanking our expert chairs and all speakers.